Thanks.
So I have an hour to fill.
30 minutes.
Yeah, and then there's 30 minutes of discussion.
Yeah.
That's an hour. So I'm going to chat. And I'm going to talk a bit about past achievements as well as future directions. If I can get this working. So going back to the beginning, so AIBL kicked off in 2006 and it got a head start on the rest of the world. That put us in a very good position because we had carbon-11 PIB imaging available. So at the Austin, we started doing carbon-11 PIB in late 2004. Now, carbon-11 is a fairly demanding tracer and you have to have a cyclotron on site. So a lot of sites around the world didn't have access to this tracer. We were the 7th site in the world to start making carbon-11 PIB, and we made it within a year of the first, in the same year that the first publication came out on PIB. So incorporating it into AIBL gave us a major head start against other longitudinal cohorts around the world. And we built on that and it achieved a lot. Times have changed. The F18 tracers have come along. All the longitudinal cohorts now have PET imaging built in, and some of them, particularly in the United States, are far better funded than AIBL. So we have to keep thinking about what our strategic advantages are over other longitudinal cohorts that are now well established. We added tau imaging in about 2013 when the first decent F18 tau tracers came along. So just to remind you, this is a negative amyloid scan. We now use F18 tracers, particularly the NAV tracer. We've always gone for the best possible tracer, and NAV 4694 is best. It's actually even a little better than PIB. So here's a negative study just showing white matter binding, which these tracers are all a bit sticky. They stick to the tubes that you inject the patient through, and they stick, we believe, to myelin in white matter. So a negative study just shows white matter, as opposed to a positive study. This is 127 centiloids, which shows high uptake in all cortical regions with relative sparing of sensory motor cortex and primary visual cortex, and no binding down in the grey matter of the cerebellum, which enables us to use that as a reference region. So just refreshing you about centiloids, this is a 0 to 100 scale, just like the Celsius temperature scale. We contributed to the development of this scale, which is now caught on internationally. It was just a group of experts that got together over a few wet red wines, kicked around an idea for standardizing amyloid imaging, and the centiloid concept was born. So 0 is the average of what you find when you do a ratio of cortex to cerebellum in young normal controls or healthy amyloid negative normal controls. And 100 is the typical cortical to cerebellum ratio that you get in patients with mild to moderate Alzheimer's disease when amyloid levels tend to peak, because they tend to go into a bit of a plateau after that. And here's the MK tracer that you saw before, very nice tracer. The first tracer that came out is fluortaucipir. This is a sort of second generation tracer that we've concentrated on, and you'll see the exquisite target to background ratio this tracer provides in people who are positive, and how there is very little uptake to no uptake in the brain in people who are tau negative. So just reviewing the achievements in the imaging field of AIBL. Well, our first paper came out in 2017 and it's had 1,191 citations to date, and this was looking at the findings in controls, FTD, DLB, and healthy controls. We had another big paper come out in 2010, which has been widely quoted, which showed the incidence of positive amyloid scans by age. And it showed that it mirrored the exponential growth in the clinical manifestations of Alzheimer's disease, but preceded that by about 15 years. So it suggested that amyloid imaging was picking up early Alzheimer's disease, which has subsequently been proven on longitudinal studies. We put out our first longitudinal study results in 2011, which has also been highly cited. A big paper in Lancet Neurology in 2013, in which we documented the trajectory and the rates of accumulation of amyloid compared to neurodegeneration and cognitive decline. And we've been more recently publishing papers on tau imaging, some of which have been highly cited. We also contributed greatly to position papers and collaborations worldwide. Some of these have been pretty huge, such as the NIA Alzheimer's Association guidelines in 2011, which you can see 6,500 sites. The NIA research framework, which in 2018 has already had over 4,000 sites. So we've contributed to the worldwide literature, we've contributed to guidelines, we've contributed to standardization of amyloid, we've contributed to appropriate use criteria in clinical practice. More recently, this is what we've been up to in the imaging field. We are now looking at reactive astrocytosis with a marker tracer called SMBT1. This actually binds to MAO-B. This is a sort of fortuitous development. We've been working with the Tohoku University group on tau tracers, and they came up with some tau tracers, a series of them, and Victor Vilmagno was particularly important in their clinical evaluation. And they looked okay, but they had a lot of off-target binding in the basal ganglia. Then we did some studies, and so did the group in Montreal, blocking MAO-B with Deprenil, and suddenly these tau tracers disappeared. Almost entirely, not entirely. There was a little bit of signal left in the cortex. So it became apparent that these tau tracers were really MAO-B tracers. So Tohoku went back and modified this tracer to make it a more purely MAO-B tracer. Now, MAO-B is expressed by astrocytes when they're reactive and active. So we're now using this to look at reactive astrocytosis across the Alzheimer's disease spectrum. And we published the first paper in 2022. What it does show is an elevation in healthy controls who are amyloid positive. So there's an early reaction from astrocytes to amyloid. And then there's a further boost in the signal when you get into the dementia phase, which may be when there's more actual degeneration occurring. So that's quite exciting. Victor's is continuing to work with us, even though he's back in Pittsburgh. He's just secured, as one of 4 PIs, a $60 million grant to further pursue this area. I'd have to point out it's another competition problem we have in Australia, trying to compete with the United States, given the relative funding that's now available, thanks to the great work of the Alzheimer's Association in the United States, who've continually lobbied their Congress for more money for research in Alzheimer's disease, and they've increased funding by billions of dollars every year. So we are competing now to a very well-funded dementia research environment in the United States. We've also been looking at contributing data to major international groups. Here's one that's included AIBL data amongst 19,000 people, looking at abnormalities across the Alzheimer's disease clinical spectrum. We've been pushing our tau imaging with the MK6240. We've put some preprints out, and publications are under review and some publications are through. We're looking at regional tau accumulation across the AD continuum. We're looking at mesial temporal tau and amyloid negative. We've looked at tau, amyloid and glucose metabolism in traumatic brain injury in Vietnam War veterans, and also motor vehicle accident head trauma. We're assisting the development of blood biomarkers, and we've published several papers. There's a very good one that's come out from Ralph's group recently from AIBL that they'll talk about some more, I'm sure. And we've also used the Janssen p-tau 217 plus. And of course, you've heard from Colin about the mass spectrometry work that we've been doing with Japan. It's all depended on amyloid imaging as the gold standard. We've been looking at associations of amyloid level, clinical progression and longitudinal cognitive change in normal older individuals, just published last year. And last year, we also published something on the relationship between amyloid and tau levels and its impact of spreading. So just going through some of those recent publications. So this is the timeline of amyloid accumulation that we've derived from interpolating the longitudinal data. And of course, we've been going since 2006, so we've got a lot of longitudinal amyloid data now. This is that paper that came out last year, looking at cognitive trajectories based on the amyloid level. There's this very irritating misuse of amyloid. Amyloid accumulation is continuous. The thresholds that are picked, there's no absolute threshold for amyloid. It depends on your question. And the more amyloid you have, the worse off you are. There's also a relationship between the amount of amyloid in the brain and the duration of which you've been developing or going down the Alzheimer's path. So in this paper, we looked at cognitive change over 5 years or more. We've got over 500 healthy controls with an average of 5 or more years of follow-up now that had a baseline amyloid scan done. And we broke it down by centiloids. And basically the green and blue is up to 50 centiloids. And you'll see nothing's happening. Once you get from 50 to 100, you hit the orange lines. And so in healthy controls, if you're over 50, you have a demonstrable cognitive decline on sensitive cognitive testing. And the red is people who have over 100 centiloids in healthy controls. And you can see things are not good for those people. So it's the amount of amyloid that determines your rate of progression. And that's backed up by this finding from a publication from Vincent Dorr, who last year. Very important finding, probably underrated, and we've probably hidden it a bit by putting it in the European Journal of Nuclear Medicine. We should really try and publicize this some more. But tau doesn't start accumulating in the brain, and that's mesial temporal tau on the left and cortical and the temporoparietal on the right, until you hit at least 40 centiloids. So this fits in nicely. The cognitive change and the tau accumulation occur later. They occur once you get above 40 to 50 centiloids of amyloid. So if you're running preclinical trials for a couple of years and you want to see if your cognitive endpoint, if your endpoint is cognitive change or slowing of cognitive decline, there's really no point putting those people in a trial if they've got less than 40 centiloids. So this is a bit of an issue, I guess, for the AHEAD study, which is a 20 to 40 centiloid group and a greater than 40 centiloid group. There is not going to be any cognitive change in that 20 to 40 group over the 3 to 4 years of treatment. The Skyline study from Roche actually coincidentally has ended up with about a 40 centiloid threshold for their study, which is probably a better move. So these are important findings that influence clinical trials, and particularly in those aimed to prevent Alzheimer's disease. This is something we currently have under review, looking at the longitudinal data we have from our MK, and it reflects something that's quite interesting. There's the mesial temporal progression of accumulation, there's the temporoparietal, and then there's the rest of brain, which is predominantly frontal and some occipital areas. And what you'll see is that the mesial temporal goes up first, but then it plateaus. So by the time you've got Alzheimer's disease clinically, your mesial temporal tau is no longer going up. In fact, it looks like it's going backwards a bit. If you look at those little bar graphs on the right, the AD are the red bar graphs in the mesial temporal is the top cluster. The temporoparietal regions go up quite nicely, and then the frontal regions go up later. But the duration of this increase is pretty similar to amyloid. It's coming after amyloid, but it's a slow process. So it just further confirms that all the pathology of Alzheimer's disease is a very slow process, indicating there's good windows for intervention prior to clinical manifestations. Okay, so what can we do here in Melbourne that we could think about applying to AIBL? Well, we'll be continuing our amyloid imaging, although we've really almost exhausted that. We've got so much longitudinal amyloid data. We do have to think carefully about why we're continuing to do longitudinal amyloid scans in a lot of our healthy controls after 15 years, if they're still amyloid negative. We're rapidly accumulating more tau longitudinal data. We certainly need a bit more of that. We have started this Mayo B imaging with SMBT1, again in collaboration with Tohoku University and now in collaboration with Victor, who's over in University of Pittsburgh. We do have available vesicular monoamine transporter, which is a good marker of dopaminergic loss that you see in Parkinson's disease and DLB. And we are working with Rosie Watson on her study of DLB versus AD for that. So in fact, we are doing tau imaging as part of that. So Colin mentioned nobody's put together composite images of tau imaging and amyloid. We should draw on that data to do that. We can use fluorodopa to look at dopamine synthesis if we think there's a role for that. We can look at muscarinic acetylcholine receptors. We developed a tracer called FDEX that we're currently studying in schizophrenia. But if we can think of a good reason to look in the AIBL cohort, we might do that. We've got another tracer here in Melbourne that looks at hydroxysteroid dehydrogenase type 1. It's an enzyme that converts cortisone to cortisol, the other way around, in the intracellular environment. And it was used basically to help assess the dosage of an enzyme blocker for a biotech company here in Australia. But that study's finished. We have that tracer. If anyone can think of a good thing to look at, let us know. So these are the currently available tracers that wouldn't be too challenging to do projects within AIBL if you can think of a good reason for it. So most of our work has been around the amyloid cascade hypothesis. I've given a talk recently at the College of Physicians on the monoclonal antibodies as a potential breakthrough, and I'm in Colin's camp. I think the monoclonals are very exciting, and I think the evidence for them is very strong. And I think the imaging data from AIBL has actually turned out to be strongly supportive of the amyloid cascade hypothesis. This is where the current clinical therapeutic trials are. And you'll notice this is in Alzheimer's disease, they are virtually, well, they still are dominated by amyloid. They're either in vaccines or anti-amyloid therapies. These are vaccines against amyloid. Then there's the tau approach. Now, I'd have to say the tau and monoclonals don't seem to work. Now, that's not entirely surprising since tau is intracellular and monoclonals don't actually get intracellular. They do clear CSF. There's no doubt about that. You give a monoclonal, you'll clear the tau out of the CSF, but they're not really getting into the brain where the tau is sitting and doing the damage. So it is interesting that anti-amyloid therapies do seem to affect the tau signal on PET, which does suggest they're having an intracellular effect. So that's something fascinating. We could think about some more. The other area for therapeutic trials is pretty limited, as you can see. It's mainly looking at the inflammation pathways and neuromodulating neuroinflammatory pathways. However, in the tau, there are exciting developments in the small inhibitory RNA field. For example, there are small inhibitory RNAs that can block tau production, and certainly in primates with intrathecal injection, they do seem to penetrate the brain quite well. So there are potential other therapies for attacking tau beyond monoclonal antibodies that have pharmaceutical companies quite excited and are active areas of active research. So there are now 4 monoclonal antibodies that have been proven without a doubt to clear amyloid out of the brain. And we need to keep this in mind going forward, because there's some pretty key milestones coming up for anti-amyloid therapies later this year. So by the 3rd quarter or 4th quarter this year, we will have the Roche antibody, gantenerumab, and the Eisai antibody, lecanemab, reading out their phase 3 trials. So if these live up to expectations based on their phase 2 studies, you can expect there'll be quite a bit of talk going on about needing to build a monoclonal antibody into your placebo arm for research, etc. It'll also mean that once these things are registered, we will be able to investigate them in perhaps novel ways within AIBL if we want to. So between these phase 3s reading out, it's expected that if they're successful, it'll be about a year before they get approval from the FDA, although more accelerated approval applications are going in based on, or I'm not sure that Lilly's proceeding with this accelerated approval approach for later this year. Do you know, Colin, if donanemab's going for an accelerated? Pushing for accelerated approval. So there'll be lots more talk, and we should have a very clear answer within the next 6 to 18 months about the benefits of monoclonal therapies. I'd also say that of the 4 monoclonal therapies, when there is clearance of amyloid plaques, they have all uniformly shown a 30% slowing in disease progression. So this is why I'm so encouraged. You've got 4 different monoclonals from 4 different companies, and they're all showing the same thing in their phase 2 and aducanumab in at least one of its phase 3 studies. So new ideas for imaging. Well, we certainly want to push the astrocyte activation. We've got the tracer for doing it. It's looking like it picks up an early response to amyloid. We've just started accumulating 2-year follow-up scans, and we'll continue to accumulate this data and then be able to do lots of sort of cross correlations with amyloid, tau, cognitive change, etc. We are still tossing around whether we want to look at microglia. So the TSPO traces have been around for a long time. They've been a bit problematic. Their findings have been a little contradictory. Certainly on PET imaging, there's an elevation in the dementia phase of Alzheimer's disease, but whether they're picking up anything earlier is still controversial. We would like to look for other type of neuroimaging ligands, and the purinergic receptors are of great interest, especially as there's different receptors in the M1, which is the aggressive form of microglial response, and the M2, supposedly the more protective, nurturing form of microglial activation. That concept is perhaps a little simplistic, but if we could develop traces for the purinergic system, that would be of great interest. It would be great to see what happens to astrocytes and microglia with PET when you give monoclonal antibodies. Could they be a way of predicting those that, if you do an early scan, are going to develop significant ARIA? Could it be used for modifying dosage, etc.? These are just questions that if monoclonal antibodies become available, then we could investigate some of those questions. Late, limbic predominant age-related TDP-43 encephalopathy. is a complication when we're trying to do Alzheimer's disease research, because it's found in at least 40% of elderly brains at post-mortem. Now, by elderly, I mean people in their mid-80s. That tends to be the age at which most people give up their brain. So there's no great traces for TDP-43. There was an interesting report that came out from a group in the United States based around exosomes. But the only other marker is severe hippocampal atrophy on MRI, but that's a fairly late stage finding. And then FDG PET showing severe hypometabolism in the medial temporal lobes, but also stretching up through the memory limbic system into the posterior cingulate gyrus, and also gradually spreading into the orbitofrontal areas. Now, late presents with pure amnestic dementia mimicking Alzheimer's disease, but as the disease progresses, they do become apathetic because the process is starting to affect the frontal lobes. So the FDG findings are quite reflective of what you'd expect based on the pathology and clinical progression of late. We're not really in a position to add FDG to AIBL because, as I'll show you, we're already scanning our subjects very heavily with PET. But what we could do is look at the early blood flow images of our amyloid or tau imaging. Everything you inject, every tracer you inject into a patient is initially delivered according to cerebral blood flow. So if you scan for the first 3 to 5 minutes from the time of injection, you actually get a picture of cerebral blood flow. And cerebral blood flow is closely linked to FDG measures of metabolism, so synaptic activity, etc. So this is something we could think about if we want to start incorporating potential measures that may indicate the presence of late. Basically, when we get a patient in, we instead of waiting the 50 minutes before we put them in the scan for an amyloid scan, we stick them in at the beginning, do a 5-minute scan, take them out again and put them back in at 50 minutes for the amyloid acquisition. Better still, if we could just derive this information from the 20-minute scan we do after 15 minutes, that would make logistics a lot easier. And so there is some interest in looking at this data, and perhaps by using deep learning techniques to see if we can tease out a blood flow contribution to those images that and initially correlate that with the initial 0 to 5 minute imaging and see if we get some information that might help us identify those who have a late contribution, those who have late in addition to their Alzheimer's disease. A bit tricky, but something to think about. What about new traces? Alpha-synuclein has been been sought after for many years. In fact, what's his name? The foundation with the actor Michael J. Fox, they have had a $1 million prize out for at least 7 years now for the first group that can find a tracer for alpha-synuclein. So we have a company, IC Immune, who have developed a potential tracer that binds to alpha-synuclein aggregates in brain post-mortem. It was selective for alpha-synuclein, but the binding was a bit weak. And the first PET scans that have been done and reported from Oscar Hansen and the Swedish group, the tracer worked in multiple system atrophy, showing uptake in the brainstem, but it didn't show cortical uptake. And they haven't found it actually shows anything in Parkinson's disease, which is great. So this tracer is a good first start, but it's not there yet. And we'll sort of keep an eye on this field. TDP-43, in terms of direct tracer, there's not a good target for PET imaging. TDP-43 is pretty heterogeneous in terms of its structure. It's also pretty diffuse in low concentration throughout the brain. It doesn't form any sort of amyloid which is basically how the tau traces were developed, building on the amyloid binding properties of the amyloid traces, and then modifying them so they became selective for tau. So we can't do that for TDP-43. So I'm not optimistic about a PET tracer for TDP-43. I think the blood work, maybe the exosomes might be the better way to go for TDP-43. We will continue to support development of blood biomarkers, cognitive findings and lifestyle research by providing the gold standard. So as I've mentioned, Ralph's groups recently put out a very nice paper comparing multiple blood biomarkers to amyloid PET as the gold standard. And we've also put a paper out working with Janssen on their P217 plus tau. And of course, earlier there was the mass spec paper compared to amyloid PET that was done in collaboration with the Japanese group. So that's still a very active field. And of course, the blood biomarker development, you'll hear about some more from the blood group, but it's keeping us entertained and occupied. So the last thing I'm going to talk about is something a bit more practical. PET imaging is expensive. It's also, it's got radiation. And we've got healthy controls now that have been coming along every 18 months since 2006 for an amyloid PET scan, and then we've added a tau PET scan. And now we want to add MAO-B scanning. And if we want to add anything else, we've got a bit of a problem. So it all adds up. So if you're in the AIBL study for 8 years, you end up getting 1, 2, 3. This is actually the modified. This is cutting it back. This is a proposal for going forward to reduce the amount of PET scanning that we need to do. So this is a proposal I'm putting forward that if people have 10 or more centiloids, in other words, there's something going on, we'd do amyloid at baseline, then year 2, then year 4, then year 8. In comparison, Biofinder does their scanning every 2 years. ADNeT is a bit more frequent than that, but then they don't seem to follow people and they get a new, they've just been refunded, by the way, yet again, but they tend to bring in new cohorts. So they don't end up giving, well, let's see, I might have to take that back because they are doing tau imaging routinely now as well. So that would be 4 amyloid scans. Now, tau PET, we're currently doing baseline 1 year, 2 year, 3 year, and then starting to stretch out. But I'm thinking about whether we really need to do the 1 year. Then we've got MAO-B happening at 1 year and at year 3 at the moment. But you add this all up, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. It's 10 PET scans over 8 years. It's a lot of expense. It's a fair whack of radiation to the patients and a bit of a logistic burden for patients as well. If people have less than 10 centiloids, which we can be pretty confident means they've got no amyloid based on post-mortem correlations, and the fact that people left less than 10 centiloids don't seem to do anything for a long, long time, we could just cut our imaging down to baseline 2 year, 4 year, and 8 year, just do an amyloid PET. If it kicks up above 10, then we start bringing in the tau and the other traces as well. So that's just something for discussion, because I am concerned about our cumulative radiation exposure and the cost and logistics of this exercise. So that's it for me talking about imaging, and now I think Paul's going to come up and host some discussion.
Thank you, Chris. That was absolutely fabulous. An incredible body of work. Thank you very much for contextualizing it with where we've done in the past and essentially showing us some really exciting thoughts for the future. Now, we do have folks on the call, so we're going to do a bit of morning television here, and Celine's going to be roaming around with the microphone. No fighting. So would you keep an eye out for folks who are asking questions. All right, so we heard a couple of things there. So maybe let's have a start and warm up with this exercise now. Would anyone like to offer a comment or a question, remembering that what we're doing is pushing this forward? All right, so and ask how we're going to do that forward. So may I have the first contestant, please?
Chris, I've got a question. For how long realistically do you think amyloid PET scanning will be the gold standard that we continue to provide?
Oh, provocative question.
That was the point.
And I don't have any vested interest. The blood biomarkers are looking good. They're not as good as amyloid PET. And I would think if you're running an anti-amyloid therapy, you'd use the blood biomarkers first, but then confirm your findings and use the amyloid PET to look at the effect of amyloid levels. Because the Lilly study, for example, with the donanemab showed a profound reduction on amyloid PET, like 70, 80% reduction. The reduction on the p-tau217 marker they used was only in the order of about 20%. So there's a wider dynamic range and probably greater accuracy than plasma biomarkers. There's also some concern. There's a fair number of false positives at the moment that we don't quite understand with the plasma biomarkers. But certainly, I think it's quite clear that pre-screening with a plasma test makes finding cohorts for preclinical AD far more cost effective. It reduces your screening costs by about 50%, and all the companies are moving that way rapidly. So amyloid PET's still going to have a place as the gold standard for the foreseeable future.
If I might jump in there just to flesh that out, then the two issues there. One is, what are we going to do with amyloid PET as a standard for decision-making generally, but what do we do with it in AIBL? So, for example, in your scheme here, this is exclusively a PET stat scanning scheme. Do you think some of those questions might be answered through integration of blood-based biomarkers as well? So rather than your less than 10 CLs, it might be a negative amyloid blood marker. So should we be doing that, or do you think it would be better to keep this decision-making based on the imaging, just so that there's no bleeding of it'll limit what we then can generalize, right? If we say we only scan people who had positive biomarkers, will that limit what we say if we rather just keep the decision-making on imaging?
Good point. Good point for discussion. And this is one of the risks of blood biomarker pre-screening, that you bias your cohort. So maybe if people in their baseline have less than 10 centiloids, you could follow them on their blood biomarker, and if it seems to be kicking up, then bring in the imaging to see what's going on.
I don't think we have to solve it now. It's just an idea. And I don't want to think, Chal, Cassandra?
I've got Stephanie's question first.
Oh. We can't hear you or James online.
No, it's just the bottom.
Appreciation. Right, Steph. Do you want to read? Everyone can read that, so I won't insult you by rereading.
Okay. So, Stephanie, it depends. If we were successful in developing a deep learning model or something that could derive the CBF from the 20-minute amyloid scans, then yes, we could retrospectively apply that. But we don't have the initial blood flow imaging from studies done in the past. So yes, if we can work out a way to derive it from the 20 minutes, because the 20-minute scans are actually broken up into 4 5-minute scans. So you've got these you actually have 4 images, and it's possible that blood flow may be affecting the last image compared to the first image, etc. And that's the sort of subtle signal that has to be teased out. And
if you're going to do that, like use that protocol that you suggested, you'd have to actually have someone sitting in the camera for an hour longer. That's the practical side of things, isn't it?
And I think go in and then come back out.
Okay.
It just makes it clumsy. You
Yeah.
can't just stack people up and scan one after the other. You've got to interleave them, and it
Okay. No worries.
reduces your capacity a bit. And if you're paying for camera time, it increases your
Good
expense.
point. Justin?
Okay, from the gold standard, PET image is great. But how about CSF
Oh, that's
biomarker?
predictable.
I know you are coming with that because it's pretty much close and it's much cheaper. I know you have to go get LP done. But if the neurologist or the clinician get much more training on that, much more skilled people are not scared of that, because that is very common practice in Europe. In Australia, it's not a common practice, and people, oh, LP, I go paralyzed. They got the stigma in their mind. But if that is quicker, if you got an LP there, 18-minute reaction, half hour, we have a report. So if that's had to have, CSF have been sort of parallel in the PET scan, it's much practical, and we got accreditation, and it's run to the clinical diagnostic standard. But anyway, and I think that amyloid did drop a lot early, not like linear sort of change with the disease development. But if you look at p-tau in the CSF, that may be parallel to your PET scan, going up, you're looking at 40 centiloid. Have people actually correlate what's the equivalent of CSF biomarker in the 40 amyloid? Like it will get.
Okay.
Okay. So the question, I suppose, just to reframe, Justin, is ultimately AIBL considers fluid biomarkers as well as neuroimaging biomarkers, and going forward, we certainly discussed the integration of plasma biomarkers and potential bias. But your question is, what is the role? What will remain the role for CSF biomarkers in AIBL, right? And in particular, as it relates. Have you? Of course, yeah. Yep. Yep. Have you an opinion, Chris?
Yeah, I think it would decimate AIBL if you try to replace PET with CSF. You'd have 3/4 of your subjects
Not
dropping out
replace.
overnight.
Not replace. I think there's still questions that need to be disentangled where you can answer with the combination of CSF and PET that you can't get other ways. Anyone want to go on, Colin? Go.
I've got another question about.
Oh, no, you got to address that. We can't answer that. Do you think that what's the role for CSF and amyloid? What's the role for CSF sampling and amyloid imaging?
Yeah,
as
we're
we
going
go
to talk about CSF and blood in the next session.
Okay, we'll leave it there.
We're doing a pretty good in AIBL convincing people to get CSF as well. It's hard work though.
Yeah.
And ADNeT it finds it very hard to get people back for serial CSFs.
Can I, before we go, Colin, with you, Rob's had his hand up for it, so I'm gonna.
There's two
Shalane?
microphones. I think people should come up to the front and use the microphone.
Oh, you actually, yeah, we share a little stand. That might be a better way to do it, don't you think? Otherwise,
You've talked
Shalane-
about PET as a gold standard, but what about making PET a platinum standard? I guess the point I'm trying to make is that if we can improve PET, we've already just signed last week a memorandum of understanding with Siemens to look at micro head movement to improve the quantification of PET. We're looking at there's better technology scanners out there that give a much lower radiation dose and much higher precision of measurement. We're looking at changing reconstruction algorithms, which haven't changed for 30 years. Which I think we can improve PET. If we make PET a platinum standard to measure the greater precision of amounts and at lower radiation doses and reduce the cost of PET by reducing the amount of tracer we use, do you think that's a viable way to make PET more relevant in the AIBL cohort?
Yeah, so there has been Siemens have got this new PET camera called a Quadra, and it is fantastic. We could reduce our doses 5-fold, and then this radiation issue wouldn't be of any concern at all. Unfortunately, it cost $8 million. Anyone got $8 million? No. They have installed one. at RPA in Sydney. So there's a few of them popping up. The vision camera here has enabled us to drop out half our doses. And we are looking at upgrading technologies further afield across AIBL to reduce our radiation doses and improve the resolution of the scan. So yes, there are technical advances coming that will make it easier to do multiple PET scans longitudinally without frying anyone.
So going forward then, improvement in technology. So one is improvements in cameras and that, but are there things that we can improve with methodology on the systems that we have now? Or are we pretty much running
Not
it
so
optimized?
much,
Yeah.
not so much.
Colin, did you have a question?
I want to come back to this question of Centiloid 10.
Mhm.
So you've said that they don't progress. Under 10, they don't go forward.
Well,
And
not,
yet-
not
and
for
yet-
5 years at least. Yeah.
Okay, so I want to challenge that statement. Because in the next session, you may hear that we're beginning to see blood changes at around 10. Right, so this is the critical point.
Mhm.
In the AIBL cohort, have we got enough longitudinal data on people with 10 to 15 to be able to say, do they move or not over a 5-year period?
When you say move on what?
Move on
Colin?
the Centiloid.
I'll move on. Sarah.
You see, this is a tautology. You say they don't move unless they move.
Well, that is the problem is that under 20, you have a lot of subjects who don't change over time and you've got noise. And so retrospectively, you can go back and actually see changes and things, but it's hard to use it as a prognostic risk, if that makes sense.
So the
your-
problem-
your prevalence of people who are actually very obviously accumulating is still quite low at when you've got a Centiloid of 10.
So are you saying that the
And so,
precision?
when you do changes and things, to get to a Centiloid of say 20, 25 is around about 6 years. I'll double check the graphs and I can send it to you, but it takes about 6 years. So if you started scanning a Centiloid of 10, you would be your 6-year scan or around about your 8-year scan when you're your Centiloid of 20, 25. They, well, you've got a nice age effect, so obviously they are moving, yes.
Chris is trying to tell us that they don't move.
I don't think Chris has ever
No,
said that. Chris has
that's why
said,
we only scan every 2 years. Yeah.
yeah,
There's no
so-
point scanning them frequently because nothing going to be detectable from
Although
years.
if it was a signal to noise ratio, might the opposite be true, that in fact you increase your signal, but you reduce your noise by more frequent scanning?
Not so much with PET.
Okay.
With better cameras and things like that, and I would agree with Rob and things like that, but with better technology potentially, but there are limits to what you're measuring and your time to actually getting to something that's clinically meaningful, like a cognitive outcome. All you're doing is actually just increasing the amount of years it is before you end up with a PAC signal, for instance.
So Chris mentioned at the start of his talk Tanel, I'll get to you in a second. What strategically should we be doing, right? So it's going to be difficult for us to ward off the great, swathes of publications that are coming from those American machines. Might we concentrate on less than 10? Might AIBL become the less than 10 cohort? And what we do then is actually challenge that, put our resources into that question. Just an idea.
Yeah, the problem is it's going to take you 10 years to show anything. This is the trouble. You just
Well, you get one of Rob's new
negative scan,
cameras.
negative
and-
scan, negative scan, negative scan, negative scan. You wonder what the hell you're doing it for.
Okay, thanks. No, you do, because the folks at home have got to hear. Sorry,
Wait.
sorry, Tanel, I just then you're definitely next, right?
So, so you really have data for year 8, like you have a lot of people that have done a lot of longitudinal analysis, and you're saying we're doing too often, there's not a point that we are putting a lot of radiation on them. So from that study, can't you already start to predict how often you actually should do these scans?
How
Or
often?
just keep going it? If it's like you already have a big study, and say negative, negative, negative. Okay, stop doing negative, negative, negative. Take all your study and start to actually predict how long you have to wait to at least see a change, and then put that at a time change to start doing scans, stop doing scans.
Yep.
You know, that would be a better idea.
So you use the data to predict when you're going to require another confirmatory scan. Is that sort of?
Exactly
what
that,
you're
yeah.
saying? Yeah. It's a,
Yes and no. The trouble is you don't know who's going to be on the going to go onto the path to Alzheimer's disease versus those who aren't. And the only thing that tells you is when you start seeing a rise in your amyloid.
but the point is well taken, is that on the basis of the information that we have, there's the potential to start to develop those sort of models and challenge, you know, what if we just were scanning more often folks who had very low levels of amyloid, could we? And ultimately, because we do know the truth now, in some of them, we followed them long enough to know when circumstances changed. So you do have some model of what ultimately could occur. So that's not a bad idea. Tania, sorry.
It's okay. How important are regions of accumulation? So is that information we're going to lose with blood tests?
Yes, that is true. You don't get any regional information from a blood test. For amyloid, I don't think it makes much difference. For tau imaging, it might be. Certainly, amyloid is largely a global phenomenon, and the tau really is quite different in the mesial temporal lobe versus cortical areas. They're behaving differently, and you've got the interaction with part primary age-related tauopathy you've got to tease out. And so it's good to have the regional information from tau PET.
So this is where I
Sorry, James.
severely disagree with what you've just said. If it starts in the precuneus and you can see it in the precuneus at the very beginning, why would you not report it?
Well, it doesn't start in the precuneus.
Okay, well, let's debate that, because
well,
everything that I've read,
well, all right. Orbitofrontal precuneus, posterior cingulate.
the
probably where it
default mode
starts.
network,
Yeah.
if it starts there, why not report it?
So has anyone actually used an index of burden in just those specific areas to see if that increases predictive validity or?
Yeah, that's been done.
Yeah, WashU do it regularly. Tammy Benziger does nothing else except report on the regional hotspots.
Yeah, where's that got to?
Well, she's, she's seeing changes in the biofluids much earlier than anybody else.
So we've
point.
got the data to do that, right? So what Tennille's asking is that can the blood then pick up an earlier tau, PET amyloid via the region? Now we've got the 400 people from the PET tau cohort with p-tau217 that we can look at the association for each region of the amyloid that we have, the ROIs and the plasma. So we can look at that.
Yeah, we can go back to 2006 and do it all again.
No.
We did that in
we've
the
got
early
data.
days of amyloid imaging. We did all this to death. Yeah.
The reason I asked for the mic was earlier in your talk, Chris, you talked about NAV being better than PET, the new PET. And so when I look at the data and look at those participants who we have earlier PET on from the flumetamol or flubenapir, and then they change to NAV, then we often see a large change. And so my query is for those people who do have a large change, was the flute wrong? Are we going to, is the NAV now the gold standard after PIB? So, and when we look at these people who do change quite a lot, and they're the discordant ones with our plasma, then what do we trust?
Yeah, no, certainly there's a difference when you change tracer. You suddenly get a jump. We saw that with moving from those other earlier tracers to NAV. Not so much PIB, not so much flute, but more with florbetapir and florbetaben that don't have the same degree of avidity for amyloid plaques. The main distinction is, as you say, in the low, it would affect the ability to pick up early change.
Can
we'd
we
be better off picking up?
Sorry, James.
Yeah.
I was going to say, we're coming up for 10:30 for a cup of coffee. Anyone got something really provocative to? We've all been pretty much. Go, Kevin.
So, Chris, you're talking about the use of anti-A beta drugs. I think there's a very good argument to be made that if you want to have an effective anti-A beta drug, it probably needs to be administered before the onset of amyloid plaque. And so now how can imaging help us there? I mean, you talk about amyloid as the gold standard, but in terms of actually measuring effectiveness of drug, I could make the argument it's probably more like a tin standard.
But I
Welcome enough,
disagree.
Paul.
Thank you very much, Gav.
Okay.
Have I met you before? Sir, do I know you?
I think if you can keep amyloid below 40 centiloids, then you're probably not going to progress. It's maybe eventually, but it'd certainly slow you down a hell of a lot.
All right. Thank you. So thank you very much, everyone, for this morning session. We have a cup of coffee now at the front. So go out there and caucus and think and challenge and the like, and come back in with your battle gear on.